Welcome to this high-yield explainer. Today, we're diving deep into the clinical essentials of post-operative lung atelectasis. Think of this session as your absolute masterclass. We're going to take all the crucial data, the pathophysiology, the clinical presentation, and we're going to transform you from a clinical detective into a total MSRA exam hacker. If you've been looking for that perfect, structured breakdown to finally lock in your clinical knowledge, you are exactly in the right place. Let's get to it.
Here's a quick look at our agenda for today. 1. Understanding post-operative atelectasis. 2. Pathophysiology and clinical presentation. 3. Differentiating post-operative respiratory complications. 4. High-yield management strategies. And finally, number 5, 10 essential MSA questions. We're capping things off with a rapid-fire boss battle to prime your active recall, so you definitely want to stick around for that.
Section 1. Understanding post-operative atelectasis. Okay, let's dive into this and introduce the primary culprit of our clinical mystery.
So, what is atelectasis exactly? Simply put, it's the collapse or closure of alveoli, which results in reduced lung volume. But here is the absolutely crucial point for both your daily clinical practice and your exams. This is the most frequent cause of early postoperative hypoxemia, especially right after upper abdominal or cardiothoracic surgeries. When a patient's oxygen drops early on following one of these procedures, this should literally be the very first thing that jumps into your mind.
Section 2. Pathophysiology and clinical presentation. Now we need to investigate exactly how this post-op complication operates beneath the surface. There's a really clear 3-step sequential cascade that leads to this alveolar collapse. Step 1 is all about the pain. Incisional pain, say from a subcostal Kocher's incision. And the heavy opiates used to treat it significantly blunt the patient's sigh reflex and result in a really poor cough effort. Step 2. Direct surgical manipulation near the diaphragm causes a transient, phrenic nerve-mediated diaphragmatic dysfunction. Basically, the diaphragm just gets stunned. Then we hit Step 3. Because the patient isn't breathing deeply or coughing effectively, retained secretions start to cause mucus plugging in the small airways. This traps gas, the gas gets resorbed, and ultimately you get the collapse of those dependent lung bases.
So how does this actually look when you walk up to the patient on the ward? Well, there's a stark contrast between their outward symptoms and your auscultation findings. Looking at the vitals, you'll generally see mild tachypnoea and mild hypoxemia. Critically, and you need to remember this, they're either totally afebrile or they just have a low-grade temperature under 38 degrees Celsius and there is absolutely no productive cough. Contrast that outward picture with what you actually hear through your stethoscope, bilaterally reduced air entry and fine basal crackles. Recognizing this exact pattern, that's your golden ticket.
Section 3. Differentiating post-operative respiratory complications. All right, let's pivot to the lineup phase of our detective work where we uncover the ultimate exam cheat code.
I want you to lock this timeline into your brain right now. The 1-3-3-5-5+ rule is easily your most powerful tool for the MSRA. Postoperative lung complications follow this incredibly predictable timeline. Days 1 to 3, you should immediately think atelectasis. Days 3 to 5 and beyond, think hospital-acquired pneumonia. Day 5 and onwards, you absolutely must suspect a pulmonary embolism. Seriously, memorizing this simple timeline takes away so much of the guesswork.
And this brilliantly illustrates exactly how to pull those competing differentials apart using key clinical features. Atelectasis gives you that quiet lung base with pain and a low fever. But what if you see a high fever spiking over 38 degrees, along with purulent sputum? Well, that's hospital-acquired pneumonia. What about sudden onset dyspnoea, sharp pleuritic chest pain, and marked tachycardia over 100 beats per minute, but the lungs sound totally clear? That points straight to a PE. You also need to watch out for pleural effusion, which is characterized by a stony dullness to percussion, and acute pulmonary edema, marked by orthopnea, pink frothy sputum, and that classic third heart sound gallop.
Section 4. High-yield management strategies. Okay, we've identified the culprit. Now, let's transition into how we actually fix the problem, isolating the single most critical intervention.
I really cannot stress this enough. Optimizing pain control is the single most important step. Period. Whether you're using patient-controlled analgesia, an epidural, or regional blocks, you have to get the pain under control. Why? Because the pain is exactly what's stopping the patient from taking deep breaths and coughing effectively. If you don't control their pain, absolutely none of your other respiratory therapies are going to work. It's that simple. Once you have that adequate analgesia properly on board, we can deploy the rest of our management arsenal. Step 2 is upright positioning. Simply sitting the patient at a 45-degree angle physically drops the diaphragm, which significantly increases their functional residual capacity, or FRC. Step 3 is chest physiotherapy, bringing in deep breathing exercises, incentive spirometry, and early mobilization. And step 4, of course, is carefully titrating supplemental oxygen to meet their target saturations.
Section 5. 10 essential MSRA questions. We have officially made it to the final stage of our masterclass, the boss battle. I'm going to challenge you to engage your active recall right now as we run through a rapid-fire gauntlet. Let's do this. Question 1. A patient is 48 hours post-op from an open cholecystectomy. They have mild tachypnoea, an SpO2 of 92%, they're afebrile, and they have reduced basal air entry. What is the diagnosis? Have your answer? If you said post-operative basal atelectasis, you absolutely nailed it. You can base this purely on that early 48-hour timeline and the classic afebrile presentation.
Question 2. Severe incisional pain restricting deep breathing causes basal atelectasis. What is the single most important immediate intervention? Lock in your answer. As we just emphasized a minute ago, the answer is optimizing analgesia. Whether it's a PCA or an epidural, you have to kill the pain to allow the patient to breathe deeply and cough.
Question 3. It's post-op day 4. The patient has productive green sputum, a temp of 38.5 degrees Celsius, and bronchial breathing at the right base. Why is basal atelectasis incorrect here? Got it? It's because those specific features, the high fever over 38 degrees on the purulent sputum, point straight to hospital-acquired pneumonia instead. Question 4. Post-op day 7, the patient has sudden pleuritic chest pain, a heart rate of 115, and clear breath sounds. Why is this less likely to be atelectasis? Think about the timeline. The late timing of day 7, combined with pleuritic chest pain and marked tachycardia, strongly suggests a pulmonary embolism.
Question 5. What physical positioning change increases functional residual capacity, or FRC, and relieves basal atelectasis? The answer here is super practical. It's simply sitting the patient upright at a 45-degree angle to effectively drop the diaphragm.
Question 6. We're digging into the mechanisms now. Beyond incisional pain, what direct surgical factor contributes to transient diaphragmatic paresis in upper abdominal operations? Think about what's happening during the surgery. It is the direct surgical manipulation near the upper abdomen that leads to phrenic nerve-mediated diaphragmatic dysfunction.
Question 7. Back to the clinical exam. What characteristic breath sounds or acoustic findings are typically heard at the lung bases in post-operative atelectasis? You should be listening for bilaterally reduced air entry and fine crackles.
Question 8. How does the temperature profile of a patient with simple basal atelectasis differ from one with hospital-acquired pneumonia? Remember the contrast. Atelectasis patients are reliably afebrile, or they only have a low-grade temperature under 38 degrees Celsius. They do not get the high spiking fevers that you see in HAP.
Question 9. What physical process occurs in blocked small airways that directly leads to the collapse of dependent lung units in atelectasis? This one is about the deep pathophysiology. The answer is the resorption of trapped alveolar gas distal to those mucus plugs.
Question 10, our final MSRA question. What is the purpose of prescribing incentive spirometry and deep breathing exercises in post-operative surgical wards? These therapies are specifically designed to promote sigh breaths, reopen those collapsed alveoli, and restore the functional residual capacity.
Amazing work. You've officially conquered this masterclass. You've mastered the 135 timeline, the pathophysiology, and the absolute vital importance of early analgesia in postoperative atelectasis. But let me leave you with this final thought. Now that you've got this locked down, what other postoperative clinical blind spots are waiting for you out there on the wards? Keep that curiosity sharp, use this explainer to review whenever you need it, and I will see you in the next one.